My name is Levicoff. I'm from St. Luke's University Health Network. It's 50 miles outside Philadelphia, which is where I live. We have 10 hospitals. We'll go into about 13 in a couple of weeks, and then I've got 4 more to build, so we're going to be a pretty good size hospital network. I run all the construction as far as planning and construction management and estimating and everything else, mostly GCs and CMs. We do purchase real estate. We rent a lot of real estate. We've got about 400 buildings outside the campus buildings. So as far as moderating this thing, I think the topics are really apropos to myself, and I think probably most of everybody in this room. We have 3 very distinct gentlemen, and obviously being your humble moderator, you probably won't hear from me much more, which will be good for everybody. We're starting off with Sandy Smith, who is not Cleve. From what I understand, if you look at your programs, there's a guy named Cleve. They couldn't make it. It's up to the audience whether or not what's better, Sandy or Cleve. Can I have a show of hands? You can be Cleve if you want. Is that better than Sandy?
I had Cleve in here for a while. But.
Okay. Well, I like Cleve better than Sandy.
Oh, oh, that's how it's going to go. Yeah.
Philly, you know how it is. But I think what you'll be doing is the aligning the real estate with facilities and strategic mission.
Yeah, whatever you want me to talk about.
So if you could tell everybody who
Sure.
you are, how important you are.
Sandy Smith, I'm a senior vice president at HOAG Hospital. HOAG is a community hospital in Newport Beach, so about 2 hours from here. We're trying to get the next innovation forum in Newport Beach so you can all see what it's like. We're a small system, but we are part of the Providence St. Joseph network, so the 3rd largest nonprofit health system in the country. HOAG's kind of special. It's about 60 years old. We have 2 hospitals. I oversee a variety of different things, including real estate and construction. So in terms of the aligning and the kind of brand with the strategic mission, I think this is a really important, we just had our board retreat a couple of days ago, and this is the topic that the board's really trying to consider. And it's a really pivotal moment at a time when I think the future is very difficult to predict, and at least in terms of the things that have traditionally propelled our facility strategy. And I think what and sort of piggybacking on what Michael was talking about last night, I think there's a recognition that there's this big unknown wave that's kind of coming, and we've got to be able to change our perspective from the kind of the field of dreams strategy where we're going to build it and people are going to come to us, to we've got to be able to be very nimble and very adaptable, which I think gets directly to the subjects that the rest of the panel is going to talk about. But to be able to kind of meet the expectations of our community, which is not nearly as monolithic, I think, as we've been treating it for many, many years. And so that's going to create a lot of really interesting dynamics, I think, in the marketplace. So one is segmentation of the brand and what we do. And that's kind of a scary topic to a lot of health systems, I think, because we've traditionally said we're going to provide great quality care to everybody, regardless of their ability to pay, their economic status. It's kind of the religious philosophy that underpins a lot of our organizations. But I think what we're seeing is that with the changing payer mix, the changing demographics that are kind of overtaking, we've gotten really good at delivering healthcare to 80-year-olds, but we're totally missing the mark in terms of being relevant to those next generations. Now, I'm not sure that the 8-year-old's necessarily the market right now, but we certainly have to be much more experimental in terms of aligning our health system and delivering things that are relevant to this next generation. Again, the millennials are the generation that are having the children. It is typically at childbirth when you're making your first imprint on a health system. And if we're delivering all of our care, again, for our parents, which we're really good at, we're going to miss the mark. And so we're trying to do a lot of different things where we're sort of deconstructing the organization. We're actually looking at splitting our organization, so we're not trying to pull a hospital system through the eye of the needle to do all the different things that we're doing, so that we can get out and do things like partner with LA Fitness to create an offering in their sports clubs, right? Physical medicine, urgent care. So many of those people don't have primary care doctors. It's a way to create that first connection. We're doing a lot of really interesting things, I think, in sort of the direct-to-employer space where, again, with technology companies, we're learning things about ourselves, which is, we're working with Western Digital, which is a big technology. Most of you have hard drives that were probably made by Western Digital. Their whole thing is everything's got to be paperless. We're a technology company, no paper. And it's like, yeah, we can do that. Except we had never done it before. We didn't know how to do it. And so again, when you're trying to drag the hospital and all of the things that come along with that through that eye of the needle, it's almost impossible to do it. And so what we're finding, we're having to segment ourselves and our strategies, and therefore our facility strategy to align with those different entry points. So that's what we're up to.
Well, as far as the strategy for real estate, do you foresee a change in your demographics now and you're trying to beat it, or do you now put places, your MOBs, your specialty cares, in spots to bring in our generation, which is the next one? It's going to be huge, obviously. Where do you go with that? The LA Fitness?
Yeah, I think, again, we're really in a very experimental sort of point right now where we're trying lots of different things. I'd say the place where we're moving very rapidly is into the abandoned retail space, because we can find that our speed to market and our cost of entry is relatively low. And we've got these great platforms with all the parking. You have built-in patterns, so if it's still a viable retail center, there's still stuff going on there. And it's convenient. And so for our generation, which is working, which taking time off to go experience healthcare is a challenge anyways, getting it sort of distributed in that model seems to be working pretty effectively, and we're growing that portfolio. But I think I think we're more aligned with our parents' generation than potentially the next generation. And I think this transition of, we say kind of having a foot in both canoes is the really delicate balancing act right now for the health systems.
So as far as you're concerned, if let's just say a Walgreens didn't go in because they had that split. I've got a couple of those also. So you have a high traffic count. So you do your TIS is already there, your parking's already there. So your visibility is there. How much does it matter the demographic of that area for what you want to do, which is get to that next generation? So as far as rooftops are concerned.
Yeah, I think, again, I think in this sort of evolution of we're not going to make everybody come to us, we're going to go to them, the sophistication about what's going on in our markets and our sub-markets is taking on a much more sort of retail perspective. So we're getting much more granular. Again, this sort of the whole discussion last night about data and information, where we can go out and really understand what is the population in the target market, what do we think that capture is going to be. In our markets in Southern California, traffic is the biggest determination of the geography. Right. And so within a certain sphere of traffic or traffic patterns, we can identify very specifically what the demographics are, who we're serving. And then again, if we have to take and distribute subspecialties into those communities and creating the right kind of platform for that to occur, it gives us the ability to know what specifically is most likely to be of value to that customer, which is a very different proposition than we've got a really compelling, beautiful hospital on a hill in Newport Beach, please come to us. And so we're learning a lot from that process. And honestly, we have stubbed our toes in that learning process quite a bit. So this is kind of the learning phase, and trying to get the organization shift is a really interesting challenge.
And to dovetail what Brad's going to be talking about, you have an infrastructure's already in the building. So you have all your feed is in the building, your HVAC units are already on the building, but you're going on to retail. So you're going to decide whether or not something that's there or what's not there can either be augmented to fit what you're putting in, or you can actually use it. So it gets you speed to market as far as doing more for less. In a way, you're getting in there much faster. Are you leasing it for the most part now, or are you buying them?
Yeah, we actually, so again, we have 2 physical hospital locations. We only own one of them. We lease the other hospital.
Oh, okay.
And, it's sort of like, when we first did that, everyone's kind of like, well, that doesn't seem like a good idea. But honestly, it's like, why do we need to own the infrastructure to control it and brand it and operate it? And so I think that mindset has really been freeing in terms of our ability to go out. We have a variety of different things in our portfolio. I don't think we'd ever let go of the Newport Beach Hospital, but I think we in the facilities business have to let go of the notion that we have to own everything to control it and brand it and deliver it.
Well, it frees up your capital, obviously.
Yeah, and so in the health system, our new CFO is from Microsoft, who really didn't own anything of their facilities. And he's like, why do we have all this, we've got billions of dollars on the balance sheet in real estate. How is that helping us drive transformation? And so I think it's incumbent upon all of us to let go of some of those preconceived notions.
One thing you don't have, obviously, then is the asset in order to get the money to build. So what you're borrowing money on, I don't know, do you have any idea what you're borrowing money, at what % you might be borrowing money to build?
Yes, but I'll be shot for disclosing.
Oh, okay. But for the most part, it is the give and take. How much do you want to own and how much do you want to lease versus what you're really worth and to borrow money. Back to the doing more with less. Brad, introduce yourself if you could.
Sure. My name is Brad Lahr. I live in Rochester, Minnesota. I work for the Mayo Clinic in Rochester, which is an organization that's been around for since 1889 was the first hospital that was built. And so I've been there 20 years. And so I came into a kind of a rich culture, rich history of how things were done. And much of that hasn't changed, honestly. And so this is kind of an interesting topic for us because we're in the middle of kind of always looking at ourselves like, can we keep doing this like we've always done it? And it's almost the opposite of what you were talking about. We've always built 100-year buildings. We've always maintained them very well. And so it's a time of change. But a couple of the unique things about Mayo is it's a physician-led organization. So every leadership position has a physician administrator leadership group, and it's a committee-funded and committee-run organization. And so when you talk about doing things more with less and faster, it's not really in our DNA to do things fast. We've been very slow-moving. Just committee structures in themselves are a slow-moving operation. And so that's been challenging for the organization to figure out how to kind of adapt and make decisions more quickly. And it's been something that in the last 5 years, I'd say, has gotten a lot more attention. Like, are we nimble enough to adapt? And so one of the things we're in the middle of that is restraining us quite a bit is we're going to a converged medical record. We went through a major process and we're implementing Epic right now. So our capital dollars are being plunged into this $1.2 billion kind of convergence of a medical record across the enterprise. And so that's been a challenge for us. But one of the things I wanted to just mention that we do, and I don't know if it's unusual for large organizations, but on the construction side, so we move about 180 capital projects a year through our system, and we got 30 people doing it. And so we have standardized a lot of things. We have, well, first of all, we have arrangements with the city. We have a PUD, a Planning Urban Development, so we don't have to go to get city public review on all of our projects that are within that zone, that medical district. So that's one thing that kind of speeds things along. So we talk about doing things faster. That's one thing that really helps. As part of that agreement, every 5 years, we have to do a major effort and document everything that's changed within our footprint and staffing, parking, green space, material handling, and really list every single project we can dream that would happen in the next 5 years, and that becomes a council-approved document and a public document. And so that's one of the ways I inherited this. We didn't invent it. Many organizations probably have done this, but it does help us move projects through the system faster. And then
Is that from development all the way through construction? You don't need approvals for?
we don't need the typical planning and zoning type review. We still get building permits.
Don't need that
but
either.
We don't need any of the public reviews because of that.
How big of an
Special
area?
medical district.
How big of an area does that cover?
Let me think. 50 acres, and another 30.
So it's all within your own property?
Yeah, yep, it's within our
So
property.
you don't have a master plan that's already been, let's just say NIPD's approved or anything like that through the Conservation Authority?
Nope.
So you have to do it each one individually, and they let you do it without
Yeah.
applying? That's terrific. That is getting faster.
Yeah.
That's pretty cool.
Again, I don't take
I
credit
don't
for
think I'd
any
get
of
Philly
this.
to do that.
I inherited that, but the other thing then we do, I guess, is we have, we're real standardized on our contracts. So we have preferred contractors and design firms. We have master agreements with 20 design firms. Some of them compete with each other, some are more specialty. And then we just write amendments. So our process for a project manager to get a project kind of bid and signed up and started is, we're not negotiating contracts ever. We just,
From conception to implementation, 50,000 square foot MOB. How long?
how
Typically,
long?
with this system, it sounds fantastic. I'm salivating here.
Yeah.
Love to be able to do that.
We don't build new buildings very often, honestly. That's another issue that we deal with. We have 100 buildings, 16 million square feet, and so we're churning a lot. We're
Okay.
remodeling, we're updating.
Okay.
So we did a bed tower, a couple years. I don't know.
It is typical.
Yeah.
Okay.
I mean, it still takes time.
Yeah.
One of the reasons it takes time is our culture is we involve physicians and nurses and all the staff in the design. We don't give them the product. They're part of the process. And so there's good and bad in that. It slows it down, but when they get it, they're not 100% happy, but they were a part of it.
Right.
And so that means a lot of 6 a.m. meetings and 5 o'clock meetings because they're doing practice work during the day, and so we're meeting early and late to get
Well,
those.
they're making the money that we're using to
Yeah,
build.
that's usually the
We got to work
the-
around
the-
their
The
clock.
final line is, well, I need to go make some money so we can do this.
And you're doctor driven, so
Yeah.
your CEO is a doctor. And,
Yeah. Shared service, I don't know if you guys are probably familiar with that term, that was new to me, but our enterprise is moving to a shared service model for all support functions, and much of it's done, human resources, IT, they're enterprise groups now. They weren't over the 150 years they grew into Florida, Arizona, Rochester, all had their own entities, and that's been a big change, big shift. I think the service dropped quite a bit, honestly, and that's been recognized now, and so we're trying to get the service back up. People don't like calling 1-800 numbers to get push forward to have your computer installed and all that stuff. So shared service is a big thing the organization's going to try to reduce staffing, frankly. And so facilities we were the last ones, so we are 2 years into that. It's a very slow-moving process, but trying to do more with less, I guess. We just got in February. The last thing I'll say here, I'll shut up, is we had $300 million, 2 projects for $300 million approved in February, and we got no staff to do it. So we got to do all that with the people we have, and that's on top of all of our 180 projects. And so that's just the expectation that we figure out how to get it done. And so we're doing that. I don't know if we're doing it very well. It's kind of like what you were saying. It's trial and error. It's, hey, let's contract these 10 projects. They're low risk. We'll hire a PM to do those and see how it works. And so we're dabbling in different things to try to get it all done. We have a queue. We have 40 projects that are unassigned right now.
what do you consider a project? So as big as you are, you have probably in-house facilities at most of your establishments that take care of the small jobs.
Yeah.
When you say 180, what's...
Yeah, so at where I work, it's kind of interesting. We have 30,000 as a break point. So we have about 6,000 projects. We do under 30,000 every year, and then we have 180 that are 30,000 to 400 million. That's so it's capital over that, and so.
So anything bigger than 30,000 is considered a bigger project? It goes on your 180.
Yeah, I mean, they average maybe 2 million, but I'm just
Yeah.
saying, there are a few of these $80,000 things that, just go through the system quickly and get done, so.
And the standardized contracts basically can fit
Yeah.
everything. And they've already been vetted, and those same contractors have already read it. You've changed or added or subtracted whatever language was necessary to appease yourself and the contractor. So you have one contract, let's just say that goes to everybody.
Yeah, there's 2 buckets of contracts. I may have skipped over that. So the under 30,000 work, which is many, those are a 2-year agreement. They're hourly. We got a couple hundred people on site every day that aren't Mayo employees, they're contractors, and they just get work tickets, and they take care of them. So that's one contracting
It's more
method.
clerical almost.
Yep, and then the other one is the projects that are over 30,000 up to, the 400 million, and that's all one bucket of contracts, so.
Okay. So you never have to renegotiate anything?
That's-
Because you might get a $300 million contract with somebody who used to do $20 million projects with you, and he doesn't want to renegotiate a contract to do a 300?
Yeah, they want to, but.
But they don't, because they're working for Mayo.
Well, I mean, we try to have this partnership where,
Yeah.
you got to look at the portfolio work. There's going to be some projects this size and some projects this size, and we're hoping you work with us on all of them. We require them to bid on every project.
Oh,
So they
everything's-
can't cherry pick, they can't cherry pick the $20 million project and not bid on the $2 million project,
So is it mostly design bid build?
mostly. That's the other thing we're trying, and we're behind on this, I think. I don't know. I'm very interested in the one session on project delivery because we're doing our first.
I'll be in that too.
Yeah, we're doing our first integrated project delivery project. It's a $70 million vertical expansion, and we've never done one before. So it's a modified version. We don't have one contract, but we call it a collaboration contract.
Yeah.
So we're seeing how that works.
Well, I don't want to alienate any of the architects out in the industry, but secret is IPD, we've been doing it for 40 years. They just put another name on it.
Yeah. Yep.
So you'll see it. It's going to be very familiar. It basically puts a gun to people's heads, but the gun has always been there if you manage a project right.
Yeah.
So it'll be interesting, especially the amount of work you do. So thank you, Brad. I didn't
bet.
thank you. Sorry.
That's all right.
Sandy, I am
Not
very,
cleave.
I apologize that I didn't thank you. Next, it's for the next topic. It's the meeting, the evolving expectations of healthcare consumer. And Jim, introduce yourself, please.
Thank you. Jim Mladucky, I'm Vice President of Design and Construction for IU Health. Our main hospital is based in Indiana, in Indianapolis. We have 15 hospitals throughout the state. We're the largest healthcare provider in the state of Indiana. About just under 10,000 physicians, 25,000 employees, and about $5 billion a year in revenue. We are a AA bonded rated company and usually about 390 to 400 days cash on hand. We are embarking on a very large project, on actually 3 that has turned into 5. We're replacing our medical center on our downtown campus, so we're consolidating University Hospital and Methodist hospitals onto one campus. That's taking up quite a bit of my time. We're in the process of doing operational planning and re-engineering right now. We have our master plan in place. Bloomington Hospital in Bloomington, Indiana, which is in integration with the University of Indiana, bringing health sciences to that campus. We're taking over the driving range of the IU's golf course to build that. So it's about 700,000 square feet.
Doctors can't be happy about that.
Well,
Doctors are not happy about that.
part of the deal, part of the deal was relocation of the driving range
Oh, right.
and updating of the golf course. So what I understood, it was the worst golf course in the Big Ten, but now it'll be the best. So we'll see. And then Riley Children's Hospital, which is probably most of you, I'm sure, are familiar with. We're doing renovation there to bring our birthing program and fetal medicine program to that hospital. That's about a $142 million project in itself. So those 3 projects comprise just under $1 billion worth of work. And then we have 2 other projects that were just added because we have an expanding market north and west of us where we have hospitals, and they need a cancer center to the north, and they need expansion for services to the west, which is great for us. So we have a more or less a triangle shape throughout to cover our areas. In Lafayette, we have Arnett Hospital. In Muncie, we have Ball State Hospital, and in Bloomington, we have IU Health Bloomington. So, but the core, our academic medical center, and our partnership with medical school of Indiana University is in Indianapolis. We are looking to consolidate those two hospitals onto one. We're also going to, over time, bring the medical school to that campus. So freeing up some space for the university to expand there. The evolving and changing how people perceive, get, or receive maybe healthcare is something right at the center of what we're doing. How we change care, how we deliver care, we have a once-in-a-lifetime opportunity, we feel, to reinvent ourselves, reinvent that care model, and make sure that we do focus on convenience, on access, on navigation and affordability. And that has to do with the physical aspects of any project. So how does the hospital respond? How do these clinics respond? How does our network respond? But it's also how we respond to the communities that we work and live in, and how we support them through population health and other means. So, it's not all about bricks and mortar. It's more about getting that access to the millenniums. And I think one of the things that we've really focused on is what the expectation of the customer is. So it's not, I found this fascinating. We've got a group of people, and that's all they're doing. I think there's about 6 or 7 of them. And they're part of the marketing and also the strategy group that we have. Lots of different backgrounds. But what they've found is it's not about age. It's really about mindset. You can have, some of the baby boomers or the greatest generation who are very active on the internet and who use it all the time and are very comfortable. And you can have millenniums that aren't. So it's understanding those personas, understanding those avatars, and designing around those. So it's different than I thought. And we've put a lot of research into this, and that's being rolled out now. So, if you think about it, right, so convenience, access, navigation, affordability. How do those 3 things come together in anything that we do, out in the community or on each of the campuses? We're also focused on destination medicine. Destination medicine defined by keeping the services close to the patient. So instead of creating this new megastructure for the academic medical center where everybody has to come to that campus, how can we provide services in Bloomington, in Arnett, at Muncie, at Frankfurt, at Bedford, at our other critical access hospitals? How can we better care for the population in Indiana and work to make them the healthiest population in this state or in the United States, which is it's going to be a Herculean task. Right now, I believe we're 34th, least healthy. We have the highest, I'm told, the highest infant mortality rate in the United States. So it's, you hear about the opioid crisis. We're absolutely living it, especially in southern Indiana. So Bloomington alone will have, on a weekend, 23 people who are in the hospital for that. So it's definitely a focus of ours. So that expectation, people expect to be in a safe environment. People expect to have high quality care. People expect to have it convenient. So what's going to differentiate us, right? So how do we differentiate ourselves? And I think any of us. So, what are those services? What are those things that we need to focus on? So we are working hard to be, to move our scores in patient satisfaction up. We're focused on quality and safety measures, and we're integrating research as well as education in all of our facilities. So we've focused on precision medicine, and I sat with someone from the City of Hope the other day, or last night, I should say. And that's a big part of what they do. And it's really looking at genomics, understanding that genomic code, and tailoring medicine that will prevent or at least control cancer. Cancer has changed over the years. It'll continue to morph. I don't think we'll ever get rid of it, but it's starting to become more of a chronic illness. So how can we manage that care at Bloomington, at Bedford, at Frankfurt, at these smaller hospitals, but if they need the specialty care that precision genomics allows them, they're able to get it, both at Bedford, well, probably our regional hubs, at Bloomington, at Muncie, and at Arnett in Lafayette. And then when they need that, absolutely that specialty care, we have that in our campus, focused with Simon Cancer Center. So it's the model that we're moving forward with, and I think, you know, the whole population health thing, less bricks and mortar, more about connecting with the community through the way they expect to be connected. If it's by smartphone, if it's by tablet, if it's by TV, if it's by some other means. That's where we're headed. Some of the things that Brad talked about were in our infancy. You know, it's some of the things that he had talked about as far as master service agreements. We're just starting that. We did negotiate with certain contractors, and we set those, and we will not change them. You know, I think that's key. If you want to work with us, this is the contract. We have at Simon Family Center at Riley Children's Hospital, that was about a $500 million project that finished in 2011. We did IPD. Contractors loved it. So when we audited, any contractors out there?
Wow.
No hands.
Okay. You're afraid? Or?
So here's the secret, guys. They made a 20% profit.
I was with a couple big contractors before I became an owner, which is only the last 6 years. I love them for that reason.
Yeah.
But as an owner, you guys got to be careful.
I think it's to your point, the collaboration aspect of it is fantastic. And it's really just about managing the project, not allowing them to manage the project.
Right.
But you need to have Brad's staff overseeing what those contractors are doing and challenging those things. And everybody has to be in business, and everybody has to make a profit. They won't.
It just can't be a pig about it.
That's exactly.
That's what it is.
So,
That's what it is. When you say get your services to the people,
yes.
in your state, it's a big state, and you're pretty much the big papa bear of that state.
We are.
Are there any population growths that are outside
Not outside of Indianapolis. Indianapolis is growing. It's, I think, so full transparency, I've only been there for 18 months. So before that, I was at Northwestern Medicine for 6 years and oversaw their program there. But what I would say is Indianapolis is, last year, I think it was ranked in the top 10 for sure. Well, for growth, but also for cities that millennials want to live in. So, it's I tell people on one side it's very progressive. You feel like, it's a one city county government. There's lots of different programs for bike sharing and Blue Indy car where you swipe electric cars and all kinds of things. But on the other side of that, a lot of people smoke, a lot of people are overweight. It feels like, you're maybe back in 1950.
And yep, in the rural areas specifically.
Yeah, especially you get outside of Indianapolis and it becomes rural pretty quickly.
And is it just Indianapolis that's growing in that state?
Yes.
Okay.
Yeah, so,
Not
our
the
southern...
college towns or anything like that?
Well, college towns ebb and flow, right?
Yeah.
So, when school is in, Bloomington has, 70,000 plus people. Or Lafayette with Purdue University has, another 50,000 people. But when summer comes, they're not nearly as populated.
For the big projects you're doing right now, are they going to be IPD also? Or?
No. So we've I shouldn't say no.
Okay.
Every project has its own life, right? So every project has the right delivery model. Not everything one size fits all. So a lot of the projects that we're doing now it's I would say a modified CM at risk that also incorporates design build or design assist. Get the teams together early on and put them all in a room.
Mm-hmm.
So at the risk of maybe seeming slightly argumentative, but
Nah.
it's who
I'm holding myself back.
I'm Cleve.
So you go ahead.
I'm Cleve, just because of that. But there were a couple of things that I heard, that we've kind of talked about that for me it's kind of speaks to the root of some of our challenges. We're in this room talking about delivery models. The people who are accessing our services, they don't care. They don't care. We talk about affordability. That's supply chain stuff. What they want is value, right? And value is outcomes over cost. And so if the things that we're doing aren't improving outcomes, then they better be working on the cost component of the equation. Nobody cares about affordability except the CFO, right? That's what they're worried about. And to be relevant, I think, in the future, and to be relevant, because the payers are all like, hey, by the way, we're going to totally rain on your parade right now. Mm-hmm. All of those things that you've been doing where it's like, oh yeah, we're going to take it from inpatient to outpatient, and then we're going to charge you inpatient rates, hospital rates. The Blues right now are saying, hey, you know what? We're going to pay you the lowest common denominator in your market, and you guys better figure out, because other people are making a profit at that, you guys better figure out how you're going to make a profit, because we're not going to continue to pay. Now, if you have a monopoly in the market, you may be able to, hang on a little while longer, but this whole proposition is changing really rapidly. And I think we haven't, again, there was a big move towards population health, and we're going to take first dollar, and we'll manage it, and that really hasn't happened. And all the accountable care organizations, that was the big topic for 5 years. It's not even on most of our conversations anymore. But this whole notion of getting ready for this big change, we don't know. I mean, in the last 6 months, we've been on this roller coaster of Affordable Care Act, no Affordable Care Act, whatever. But the reality is there's too much money in the system, a lot of which is going to come out, and how do we provide the services that are needed in the community from a care standpoint, and then how do we enhance value and differentiate the brand, that segmentation piece. And I think we've got to be very careful as an industry, particularly in the facilities piece, because we get our process so long compared to the rest of the cycle, right? It's like, 3 years because you have a negotiated agreement. It's like, so what's healthcare going to look like in 3 years from now, right? We'll be right in the middle of the next election cycle. Who knows what's going to happen with, taxes or affordable care or, blah, blah, blah. But this whole notion of we've got to figure out how to provide and enhance value and be able to tell that story, that is really critical. And it's not about whatever our contracting strategy we have. If we have the wrong contracting strategy, shame on us as being the real estate and facility professionals.
Sure, but what I would say, though, Sandy, is being able to capture those dollars and making sure that you get value from that delivery model so that those dollars can be put back into care and providing perhaps the research necessary to change outcomes or providing the extra nurse at the bedside.
But isn't that's the cost of entry, isn't it, in our world?
Well, so what I'm saying is delivery, how we deliver, how we do our job, we're stewards of the organization, right? We have to be able to provide that value at the right price, and any money that we don't use needs to go back into the organization so that care can be provided. We're just a support platform. We're not the main industry. that we're focused on. And I agree with you as far as affordability. I get what you're saying. But that value proposition is a whole lot more complex than you just said it was.
There are lots of elements in the cost structure for sure, but I don't think the value proposition itself is complex.
It's a very complex equation.
I think he's going
Do
to
you-
find
do
out
you-
when he starts doing it. What did you say? How many billions of dollars is scheduled now to go in? 180 jobs over a certain amount of money. And
Yeah, every year.
so if he's got, let's just say, I mean, we just got done with almost $3 billion in the last 6 months, in his last 6 years. And that $3 billion was allotted basically on a master plan that I had put together, just threw some numbers out. And it came in right around $500 million less, and it was over a 4-year period. So in that time frame, that money, I built a bunch of linear accelerators and a bunch of women's breast centers and a bunch of, so it did affect the care model. It did affect the patient tremendously, what we did in the construction and planning and facility side. Specifically, as far as I'm concerned, we are at ground zero because I don't know how you guys look at or how your hospital functions, but I can't think of anybody who spends more money than we do. I mean, IT, you're right. But that's baffling you with the bold. We actually do something, okay? Sorry. You can tell me all you want with the Cat 6 costs, but I don't believe it. But in that sense, if you think about it, that money that changes hands is healthcare. Is that person, for every dollar I save, I think of that next person that I could put a urgent care closer to and bring it to the patient.
Right.
That dollar I save might be, another, cyber knife or another robot.
And I would say that value, again, might not be bricks and mortar. It might be another something else. Mm-hmm. And that value equation includes quality, safety, patient satisfaction, access, divided by cost.
Yeah, again, from a hospital standpoint, sort of the triple aim, it's a great thing. It actually got us talking about quality and safety, in health systems as opposed to access and scale. But again, I think we've got to be very, very careful because you want to maximize value. So if we start the discussion of, I have all the hospitals I ever need, I never need to build another facility.
I got 6 more coming.
If we start from that mindset and then really provide the rigor of, okay, so if we do need more, what do we need and where should it be? How do we maximize the value? You can end up with a very different set of solutions than, again, the hospital centricity, which is a very powerful, I'm part of the senior management team at an organization. It is a very powerful group of physicians and opinionated, and they're like, oh, we've been talking about healthcare reform for forever, it's never gonna happen, and it's here, right? It's because the dollars are getting redistributed, and I think we have to be very careful as an industry not to be telling ourselves what we want to hear, which is we provide fantastic, value, right? And because, again, I think, so we may not like IT, but man,
it's here to stay.
It's the place, right? Mm-hmm. It's the enabling tool, so.
So, one measure might be likelihood to recommend. So when you have an experience, how likely are you to recommend to your friend or family member to go back to that location or back to that service provider?
Well, if you're asking me, I never want to see a doctor ever.
Right.
But if you have to, right? So is that a measure that we can agree on, likelihood to recommend?
Yes, but again, I think it's segmentation because the thing that is going to, if you're asking me and you were asking my wife, we would have probably very different perspectives. So again, we're creating a one-size-fits-all platform. She's very satisfied because we've designed it around her needs. For me, it's fingernails on a chalkboard. I don't want to be there at all, and that's not how I want to access it.
Right. Well, and that's why,
Well, we're getting real close.
that's fine, just
watch
one
the
last
clock.
thing. That's why where we're focused are, what are those personas? And how do we better provide care that people do want and the way they want it? So,
Anybody want to chime in? Otherwise, I'll sit between them. Anybody?
It's very bright light, so you
And
have
I-
to jump up and
yeah,
down
we won't
if
even
you
see
want
it.
to ask questions.
The main thing to me, I want everybody to understand, I'm not against technology. I love technology. I cannot stand the cost of the technology. And that's about the difference. Anybody at all chime in on any of this?
Okay, we're just going to continue
What'd
to
you
argue
think?
up here.
Okay, we're good. Thank you very much.
Thank you, guys.